What to expect from having an induction of labour. You will be given a date range, and most women will be called into Hazel ward when there is a bed and a midwife available to start your induction of labour process. Some women will be called into delivery suite or the birth centre depending on additional factors. In addition, women who are having twins, a baby under 37 weeks or a baby who is suspected to be under the third centile will be called by delivery suite. When you arrive for your induction of labour, please bring all your birthing bags up with you. There is a patient kitchen and a shared space called the Woodland Suite where you can make teas, coffees as well on the ward, and a courtyard area to walk around too. There are birthing boards you can use during your induction of labour and during your birth. The process of induction consists of 3 key stages. It's important to note that not all women will need to go through each stage to get you into established labour. However, if you haven't had a baby before, it is more likely that you will need to go through all 3 of these stages. The stages include cervical ripening, breaking or releasing your waters known as an ARM, and then starting the hormone drip of synthetic oxytocin.
Cervical ripening. The first stage of induction is to talk you through the induction process. Complete your blood pressure, your pulse, your temperature, feel your tummy, check your baby's position, and then monitor your baby's heart rate. Your midwife will then examine your cervix with your consent. In the initial examination of your cervix, your midwife will be assessing many aspects to decide the first step of the induction. When assessing your cervix, the midwife is taking into account the following aspects: whether your baby's head is high or low in the vagina, how soft or firm your cervix feels, whether your cervix is behind the baby's head or near the front, the length of the cervix and how open your cervix is. If your cervix is not open, soft or thin enough to be able to break or release your waters, it is recommended to have either the mechanical balloon or the pessary with prostaglandin to help open and thin your cervix enough. In the Great Western Hospital, we recommend the Cook's balloon as the first method to open the cervix, as there is fewer unsuccessful inductions of labour, it is often quicker, and there is less chance of your uterus contracting too much and causing concerns for both mum, baby and parents. The next option, or if the Cook's balloon is not able to be inserted, will be to insert the prostaglandin. This is normally in the form of a propess pessary, which is inserted behind the cervix. For women who have started the induction where the waters have gone naturally for over 24 hours, Prostin gel is recommended. Prostin gel is the first option, which is inserted in your vagina behind the cervix.
Cook's balloon. Induction of labour using a balloon catheter. A balloon catheter is when a catheter or plastic tube is passed through your cervix and is inflated with saline and sits between the bag of waters and the base of your womb. This will encourage your body to release their own prostaglandins while also mechanically softening and opening your cervix. And as the cervix opens, it may help oxytocin to be released to create contractions. The balloon, unless it naturally falls out, will stay in for a minimum of 12 hours and a maximum of 24 hours. It is recommended for your baby to be monitored before the balloon is inserted and for around half an hour afterwards. This will be repeated when the balloon is removed, but please also let us know if you have any concerns about you or your baby so we can provide additional monitoring during your stay with us. The possible risks and side effects of a Cook's balloon include pain on insertion. The insertion of the balloon takes on average 2 to 5 minutes. There is gas and air available to help with this, and using breathing techniques, holding your partner's hand and visualizations can help. This is more common in a first baby or where there is a closed cervix compared to someone who has had babies before. Abdominal cramping. You may experience lower abdominal cramping and feel uncomfortable. However, women's feedback suggests that it's less uncomfortable to have a balloon catheter than to have vaginal prostaglandins. Ensure you go to the toilet to pass urine regularly, and you can always ask to have the vaginal wall balloon deflated slightly. Accidentally releasing your waters. When inserting the catheter, there is a small chance of accidentally releasing your waters. However, as this is the next stage of the induction process, then it isn't seen as a problem. Malposition. Due to the balloon being positioned between the baby's head and the base of the cervix, there is a small chance that it can push the baby's head further up and the baby can move into a position that isn't ideal for birth. For the same reason, it can also increase the chance of a cord coming out first when the waters break. This is rare, but it is an emergency and requires immediate delivery of your baby. If a Cook's balloon isn't able to be inserted, or alternatively does not open your cervix enough to break your waters after being inserted for 24 hours, then a prostaglandin is recommended.
Prostaglandin stage. The possible side effects of prostaglandins are nausea, vomiting or diarrhea, slight increase in temperature, lowering of your blood pressure, increased need for pain relief, uterine hyperstimulation, that's having too many tightenings, fetal distress, vaginal soreness or dryness, which can make future vaginal examinations uncomfortable. Uterine rupture, this is an emergency and required the immediate birth of your baby via cesarean section in theatre. This is very rare and more common when there has been a previous cesarean birth. Prostaglandins will stay in place for up to 24 hours. The midwife will monitor your baby's heart rate normally every 6 hours with a machine called the CTG, or more often if there are concerns. If you haven't gone into labor, then a vaginal examination will be offered after 24 hours to see if your cervix opened up enough to move to the next stage of the induction to break your waters. If your midwife thinks this will be possible and delivery suite has capacity, then you will be transferred to delivery suite for this to happen. A vaginal examination may also be offered if you are having strong regular tightenings and you are feeling you need some strong pain relief. If your cervix hasn't opened up enough for your waters to be released, the midwife will talk to the doctor about the next step forward. This will probably be to have the prostin gel inserted for another 6 hours. If there is no change after the second prostaglandin, it may be recommended that you have a different type of prostaglandin that is released over fewer hours, or it may be decided that the induction process hasn't worked for you. In this case, depending on the reason you are being induced and on how you feel, you may be able to go home and then re-enter the process in a couple of days, or may be offered a cesarean birth. During the cervical ripening stage, you will be able to have a bath, use the TENS machine, move around, use a birthing ball, having paracetamol and dihydrocodeine, or petadine for pain relief.
Stage 2 of the induction process is to break your waters with consent. This is when a midwife or a doctor will insert 2 fingers into the vagina, then slides along a plastic amni-hook along their fingers into the opening of their cervix, where the hook then pierces the amniotic sac which surrounds the baby, and the liquor, the waters, are released. The midwife will keep their fingers there for a minute or so to ensure that baby's head stays well down in the pelvis. Babies can sometimes have heart rate changes during this procedure, so we'll need to be monitored on a CTG heart rate monitor for a while after releasing their waters. If the baby's heart rate is normal, then the monitoring can be discontinued. For women who have only had a Cook's balloon induction and have not had previous cesarean birth, this may be possible to do on Hazel Ward or the birth centre. For some women, they will need to wait until there is room and a midwife available on delivery suite. Risks of having your waters released include an increased risk of infection. Once the protection of the amniotic sac is broken, this is a further increase if you have to go on and have lots of vaginal examinations, or if the waters have been released for over 24 hours. Increased pain and discomfort requiring you to ask for pain relief. Many women find contractions begin after their waters have been released. The rarer and much less common risks to releasing your waters include a vasa previa. Very rarely there may be a blood vessel running through the amniotic sac. If this was torn by the amniotic hook, it may cause excessive blood loss and would require the immediate birth of your baby via cesarean in theatre. Sometimes this is diagnosed antenatally on scans. Cord prolapse. If the baby's head isn't well engaged into the pelvis, there is a chance that the baby's cord can slip past the baby's head into the vagina. If this happens, it is an emergency and requires immediate birth of your baby via cesarean in theatre. This is more likely if your baby is not in a head-down position. Scratch the baby's head. Sometimes if the amniotic sac is tightly against baby's head, there is a possibility that baby's head may have a little scratch from the amniotic hook. It is usually then advised to wait until 4 to 6 hours after having your waters released to see if the contractions or tightening start up by themselves.
If they do not become strong and regular during this time, the hormone drip, synthetic oxytocin, will be advised. However, this is your birth, and if you would like to allow for more time to let contractions or tightenings establish before starting the drip, then discuss your personalised care plan with your midwife and doctor, who can clearly explain any risks or benefits associated. From the moment of having your waters broken or released, you can have a water birth, pethidine, gas and air, or an epidural for pain relief, in addition to the pain relief offered for the cervical ripening stages.
Stage 3 of the induction process is a hormone drip of synthetic oxytocin. It helps to create strong and regular contractions. If oxytocin is needed, then a cannula will need to be inserted into your hand or arm. This involves inserting a needle into your vein in order to put in a small plastic tube. Once the tube is in place, the needle will be removed. This allows the hormone to be administered straight into your bloodstream. The drip is started with a very small volume of oxytocin and increased every half an hour until you are having around 3 to 4 contractions every 10 minutes. Everyone responds differently to oxytocin. Some women will start contractions quickly, but others may need more of the drip before contractions start. For some women or pregnant people, oxytocin does not always work effectively. To check the contractions are helping to open your cervix, your midwife will offer you a vaginal examination 4 to 6 hours after starting the drip or after regular contractions. You will then be offered 4 hourly vaginal examinations from there on. Because the oxytocin drip has a potential to make baby distressed, your baby's heart rate will be continuously monitored. This involves having 2 straps around your tummy to hold on the monitors. These monitors are connected to the main monitor with wires. Being continuously monitored can be restrictive to your natural instinct to move around in labour, and we know keeping mobile helps labour to progress. Your midwife will support you as much as possible to facilitate your preferred position. We will still encourage mobility as the wires do stretch. There are, however, wireless monitors available in Delivery Suite to help you remain mobile. If you would like a wireless monitor, please speak to your midwife.
Risks associated with synthetic oxytocin include an increased chance of caesarean birth. From some research, there is a high chance of having a caesarean birth if your labour is induced. This can either be because your body does not respond to the induction process, your baby becomes distressed, or because of other concerns in your induction of labour. There is an increased chance of malposition in induction of labour. This is where a baby is in a position that is not ideal for a vaginal birth. For example, your baby's back is towards your back, or baby's head is in an angle, meaning the head isn't creating equal pressure on your cervix. In a labour which starts on its own, baby normally changes their position between contractions to try and find the best position ready for labour and birth. Being upright, forward and open, or changing your position regularly will help baby move into a much better position for birth. During the pushing stage of an induction of labour, there is an increased chance of perineal tearing. Perineal tearing is tearing that involves the skin and the muscle around your vagina and anus. This can be due to many reasons, including an increased chance of having an epidural, more likely to be sitting or lying down for the birth, increased chance of longer pushing stage, and an increased chance of having forceps or ventouse to help the birth of your baby. Your midwife will discuss with you whether you would like a hands-on birth where the perineum is supported and some gentle counter pressure is applied to the baby's head during the birth in order to slow down the birth of the baby's head. This may help to reduce the chance of tearing. You may also wish to consider perineal massage in your pregnancy or birthing in a side-lying, kneeling or hands and knees position to reduce the chance to take the pressure off the perineum. Having an induction of labour can increase the chance of having an instrumental birth. This is a ventouse or forceps. For the benefits and risks of an instrumental birth, please discuss these with your midwife or doctor. Synthetic oxytocin can also increase the chance of baby becoming unhappy during labour and birth, particularly if there are too many contractions. Your midwife will be closely monitoring your contractions and can help to reduce or stop the hormone drip if this does happen. If the contractions are not monitored closely, then this can increase the chance of baby needing help to breathe afterwards and potentially needing to go to a neonatal unit for some additional care. In the rarest situations, it can increase the chance of baby having cerebral palsy, but the chance of this is incredibly rare and is mitigated by monitoring your contractions closely and titrating the drip to your needs. The chance of bleeding excessively once baby is born is increased when your labour is induced. This is especially true if you've been on the drip for a long time, as it can cause your own oxytocin receptors to become desensitised and stop reacting to further doses of oxytocin. This becomes a problem when baby is born and the muscles in your womb need to clamp down to prevent the blood vessels bleeding excessively. It is recommended to have the injection for the placenta after birth to help reduce this risk. And if you do bleed heavily, this will be managed by the midwives and doctors through the use of medications, drips and massaging your tummy, also ensuring that your bladder is emptied. The drip can also cause you to hold on to any water that you drink or fluids that you may receive in labour. This can result in swelling, usually in your hands, ankles and feet, and your baby can also have an increased chance of holding onto fluid. This becomes an issue because his or her birth weight may have been higher than it would have been without the drips. Once baby has lost the extra fluid through urinating, it may appear as though baby has lost a little more weight on day 3 or has poor weight gain when next weighed. This may then lead to the suggestion that baby should go on a feeding plan. The chance of this can be reduced by your midwife monitoring your fluid intake and output closely during labour and birth, but also helping you to establish feeding with your baby postnatally. In a labour where the drip isn't used, natural oxytocin is released from your brain and into the bloodstream. When there is higher levels of oxytocin in the brain, it helps you to release endorphins, which is your own natural pain relief. Because synthetic oxytocin goes straight into your bloodstream, it doesn't cross the brain barrier, which means that contractions can feel stronger than they would have done in a spontaneous labour. The drip also tends to create longer contractions with less space in between. These two factors can lead to an increased request for epidurals and other pain relief. Induction of labour, as with any birth mode, has benefits and risks. Induction of labour, as with any birth mode, has benefits and risks. Having a vaginal birth reduces risks to you following the birth and also in future pregnancies compared to a caesarean birth, but the risks and benefits of both should be discussed based on your own medical history, your own personal feelings and your future family planning too. The alternative to having an induction of labour is to do nothing and await spontaneous labour. Depending on your gestation and the reasons to recommend an induction of labour, you may wish to discuss additional monitoring for your baby in this time. Alternatively, a planned caesarean birth is an alternative option to having an induction of labour. If you have any further questions or concerns, please direct them to your own midwives and your own doctors.